All right, do we have folks on? Yes, we have more attendees. Yes, aloha everybody. Thank you for joining us today for our April Public Health Training Hui webinar, Understanding Medical Aid in Dying. My name is Makmai Namahoy, and I will be introducing our facilitator who actually will be here and facilitating our webinar. Her name is Karen Ireland. But before we get started, I would actually like to go through some Zoom housekeeping rules. Next slide, please. Just give an introduction. Aloha, my name is Makmai. We are along with Melia Schneck, who is also on the call today. We, along with the Hawaii Public Health Training Hui Steering Committee, organizes today's training. Next slide, please. We want to give a mahalo to our sponsors and our partners. First of all, to our National Association of Social Workers, the Western Region Public Health Training Center. Next slide, as well as the Joint Accreditation, who offers today's continuing education credits. These are all projects are all sponsored under HRSA through partnership with the Public Health Learning Network. Next slide, please. Before we get started, I just want to let folks know continuing education credits that are being provided for today, which today's training will run an hour and a half. So you will be are approved for 1.5 credit hours for CHES, registered dietitians, social workers, as well as clinical social workers. Next slide, please. Nursing, as well as medical credits. Also, and today's training has been approved and planned for IPCE credits. So which means it's planned and trained for the entire healthcare team. Next slide, please. For folks that are interested in requesting their CEs, first of all, register and attend today's training. Shortly after today's training, you must complete the evaluation survey, which will be distributed to you via Mahalo email. Please complete your survey by end of date on April 23rd, which is next week, Wednesday. For those that are calling in today, please email Melia, MELIA, at hiphi.org with your name and phone number so we can ensure that you receive the Mahalo email. Melia will send out your certificates of completion no later than May 2nd. Next slide, please. Lastly, just a few last housekeepings. All participants, you are muted upon entry. For any questions that you have for any of our speakers throughout the presentation, please utilize the chat box or the Q&A box located at the bottom of your screen. And all on today's training is being recorded and will be shared on the Hawaii Public Health Training Hui's YouTube channel, which again will be sent to you via the Mahalo email as well as today's presentation slides. Next slide. All right, I'm actually going to hand it on over to Karen, who will introduce our guest speakers.
Okay. So first we have Dr. Charlotte Sharfin. She's a physician over on the Big Island. She'll provide a little bit more background as she has her slides coming up. She's both an ER doc, a primary care physician, a little bit of everything. Charlotte, can you give us a little bit more of your background?
Sure. Yeah, I am a board certified emergency medicine physician. And so I still do that a little bit. But mostly my focus is on supporting people that have serious illness and that are facing terminal illness. And I got involved very early on when we got our law because I have a nonprofit called Life and Death Wellness that I helped establish that really is about educating about living well throughout life, but especially at the end. So I am on the Big Island, but I do service the entire state at times, especially when it comes to medical aid and dying.
Thank you. We have Michelle Cantillo with us, and she is with Hawaii Pacific Health, and she is a registered nurse, ACP coordinator. Michelle, can you tell us a little bit more about your background?
Aloha, everybody. So I'm Michelle. I've been in, my background is critical care nursing, and then most recently, I'm the advanced care planner coordinator for Hawaii Pacific Health. What does that mean? I kind of do a lot of education upstream, not only to the public, but our staff as well, about planning ahead, doing your directives, end of life education. And then since the law became in effect for Hawaii Pacific Health, I've also helped the process within our organization and our community as well. So happy to be here. Thank you.
Thank you, Michelle. And we have Susan Amina with us, who's a retired, quote unquote, although we keep helping her, having her help us, nurse practitioner from on the island of Oahu. Susan, can you tell us a little bit more about your background?
Sure. So most recently, I Retired from Kaiser after 32 years as a nurse practitioner. My last position, I worked in various departments. My last position actually was a dual role of a cancer care coordinator and working closely since the law was passed in 2019 with medical aid in dying, and then also a nurse practitioner in infectious disease. So happy to be here with you, and hope this is going to be a helpful session for you all.
There's a couple of other people I just would like to introduce. Aubrey Hawk, if you can put your camera on. Aubrey and I work together on Hawaii end of life options. Aubrey, can you tell us a little bit about your background?
Sure. I am speaking to you from Volcano Village in the Big Island of Hawaii. I am a public relations consultant by trade and background, but have worked closely on this issue of medical aid in dying in Hawaii for about 12 years now. And now I serve as the project director for Hawaii End of Life Options, and very honored to work closely with Susan, Michelle, Karen, and Dr. Sharfin to educate and navigate.
And our last co-worker is Samantha Trad. She actually lives over in California, but we have been working with her for years through Compassion and Choices. So Sam, can you tell us a little bit about you?
Sure. Thank you so much for having me today. I've worked in the end of life movement for nearly a decade. I helped to improve the law in Hawaii a few years ago with a lot of actually everybody who's here today. So I'm excited to be here with everyone and help to facilitate this learning. Thank you.
And as I said, I'm Karen Ireland. I worked a lot of years with HMSA, spent most of my time in healthcare quality, health education, health promotion. And then when I got close to retirement, this opportunity to start to work with end-of-life care. Been doing so for about the last 5 years and helping to coordinate health and health education and CEU opportunities for the clinical community. And so we are all very pleased that you are with us today. And I will share my screen and we'll get started. Let me put this in slideshow. Okay, can everyone see that? Presenters, you can nod. Thank you. All right, so today we're talking about understanding medical aid in dying, and more specifically focusing on the roles of the clinical team and the requirements of the Act. Our learning outcomes today are really focusing on, one, understanding the various roles and collaboration of the healthcare providers that are really about the team-based care for medical aid in dying. It focuses as much on patient education as it is with care coordination and resource navigation throughout the process. We'll also be talking about the important communication techniques and care strategies that really help with the patient understanding, the resources and advocacy to affect the navigation and coordination for the Our Care, Our Choice Act. And finally, we always need to have a focus on the clinical competencies and legal requirements when we're talking about participation in medical aid in dying. And we'll be reviewing the law and its details. Our presenters, as I mentioned, we have Susan, Michelle, Charlotte, and I am basically the consultant moderator helping to move things forward. If you have any questions, please make sure you put your questions in the chat and we will be answering them either during the session or when we get to the conclusion. Thank you all for completing the pre-test as a part of your registration process. This helped us get a bit of a feel for what the knowledge might be out there about medical aid in dying. So we'll be talking to these various issues as we go through the slides today. We want to help clarify about administration of the medication, the role of the mental health provider, the role that the Department of Health plays in this process, as well as the role that hospice plays as people get close to these end-of-life decisions. Susan, can you help us with the definitions and some of the background?
Great, thanks, Karen. Yeah, so let's start with definitions. The first one being Our Care, Our Choice Act, which you'll see often as OCOCA. This is Hawaii state law that was effective January 1st, 2019, giving eligible adults the option to request a prescription to allow them to die peacefully. I'm just trying to move something off my screen. Okay. Medical aid in dying is the recognized medical practice in which the mentally capable adult with a prognosis of 6 months or less may request a provided prescription for medication, which they would then self-ingest. Know that as of January 1st, 2023, the term provider now includes advanced practice RNs who can be the attending or consulting provider, and psychiatric APRNs and marriage and family therapists that are now can be mental health providers. So this is really going to be helpful in terms of expanding access to care, especially on the neighbor islands. Next slide. So this is a really interesting study that was just published in February. Once you get these slides, if you click on that link below, you'll actually get the entire study. This was published in JAMA Open Network. And what it was is they looked at over 3,200 people. They surveyed them to ask them, do you know if medical aid in dying is legal in your state? So what you see listed are all the states that are currently legal, as well as DC. Medical aid in dying is legal. Do know we just actually found out that Delaware might be the next one to authorize this practice. So when you look at this, it's actually really pretty telling. If you look, for example, at Hawaii, so you're looking at approximately 47% of people who answered that they didn't know. They didn't know whether MAID was legal or not. Then you've got about 28% that are saying, no, it's not legal. They're incorrect. And then only about 23% answered yes, correctly. Yes, it's legal in our state. So, if you combine the did not know and the answered no, you're looking at about 75% of the people in Hawaii don't know that MAID is truly legal in the state. So, it's telling in the sense that there's obviously a real knowledge gap. And that just illustrates the importance of public education as well as the patient-provider discussion about this end-of-life option. And just know that, especially, I think all of the presenters here, we're not encouraging medical aid in dying. We just want people to know that it's an option. So anyway, really interesting study. When they looked at the entire population across the U.S., about 51.3% did not know MAID was legal in the United States. So again, just a real lack of understanding about medical aid in dying. Next slide. So who's eligible? You have to be an adult, 18 years or older. You have to be a Hawaii state resident. And what that means is you need to either show proof of a Hawaii driver's license, that you registered to vote in Hawaii, that you either own or lease property in Hawaii, or that you have filed a tax return in the most recent tax year. Terminally ill with a prognosis of 6 months or less, able to make one's own medical decisions, and then able to self-administer the medication. Okay, next slide. So medical aid in dying is not suicide. And so what you'll see sometimes written in articles in the newspaper and whatnot is that MAID's referred to as physician-assisted suicide, and that's an incorrect term. So this is a really nice kind of side-by-side look at the differences, right? So terminal diagnosis, suicide, not always a terminal diagnosis. There's mental capacity with medical aid in dying, not unusual to have a psychiatric disorder with suicide. The key is the patient wants to live, but they're terminal. And that's where it's really heartbreaking, right? As clinicians working with patients who really don't want to die. Typically a planned event with family, suicide is often impulsive and alone. Death is gentle versus a death that may be violent. And typically there's normal grieving, as opposed to abnormal grieving with families saying, what if I had done X, Y, or Z? So just a really nice kind of side-by-side look at the difference. And next slide. So when we look at the provider components, there's 3 providers that are involved in this process. The first one is the attending provider. So again, now is a physician or an APRN. They're the individual that do the initial evaluation. They take the first verbal request from the patient. They're ensuring that all steps are completed within the law. They prescribe the medication. They complete the death certificate. And it's important to note that what's on that certificate is the terminal disease, not medical aid in dying. And they're accountable to submit all the forms to the Department of Health. Consulting provider, again, physician or APRN, they evaluate the patient. They either agree or disagree with the assessment. Typically, they agree. Then mental health provider, and there's various individuals that are considered authorized providers, and those are listed. They're evaluating mental capacity to make an informed decision about MAID. And know that, right, these individuals are going to be depressed. I mean, they have a terminal illness. The key is that depression really affecting decision making? And that's what the mental health providers really need to tease out. So all these forms are collated and they're submitted to Department of Health. And the requirement is that these are submitted within 30 days of the prescription being written. And the Department of Health collates that data. They have nothing to do with then doing feedback back to the providers about, okay, you can proceed. Okay, so just know that Department of Health has a limited role in the process other than really collecting the data. Next slide. So attending providers' role, just in a little bit more detail, they spend a fair amount of time exploring the reasons for the patient request, and we're going to talk a little bit later about what some of those reasons are. Really looking at determining social support network, and you'll see this play out when Dr. Sharfin talks about her case study and the importance of the social support network. They do a medical review. So one thing they're looking at is, will the patient make the 5-day waiting period? So the patient needs to give the first oral request to the attending provider, and then 5 days later. The question is, can they make that period? If death is imminent, then the provider can actually waive that waiting period. They're looking at any potential physical barriers to self-administration. So what we've seen, for example, is patients with ALS, patients with Parkinson's, head and neck cancers, right, where it really might depend upon how that disease progresses. And we've seen, I've seen patients really struggle with, when do I take it? Because they don't want to miss that window of opportunity, whereas at some point they're not able to. The other thing they look at is red flags. Red flags meaning, is there something in that patient's history that's going to cause this to be a prolonged death? So for example, is there GI absorption issues? Is there a history of high opioid use that may affect time to death? And in part, that's to look at, do we need to make some adjustments with the medications? And certainly, talking to the family about time to death. This evaluation will be done in person or telehealth since COVID. And then again, they're reviewing all of end-of-life options with the patient, and this being obviously just one of them. Next slide. So just to continue, this is really important that it's patient-driven. So at any point, this patient can recant. Doesn't matter where they are in the process, they can say, I don't want to continue. Or they pick up the prescription and they never use it, right? Purely the patient's decision. They can decide who they want present at self-administration. We often recommend having a healthcare provider there, whether it be a hospice or the attending or the consultant, only in terms of it often is very helpful in terms of explaining to the patient's response, being there for emotional support and whatnot. But again, patient's decision, you can see who's listed there in terms of who they may want to be present. The time, the day, the setting, all up to the patient. The law does say this can't be done in a public setting. And then to my knowledge, the hospitals do not allow this, and some care homes don't. So again, there may be some restrictions in terms of setting. Recommended but not required hospice enrollment. And again, Michelle and Dr. Sharfin will talk more about the importance of hospice, but strongly recommended. And then the healthcare professional cannot administer the medication, right? This truly has to be self-administered. Next slide. So as I said, the requirements, there's 2 oral requests. to the attending provider, separated by a minimum of 5 days. This must be documented in the medical record. And again, that attending provider has got the ability to waive that period. There's one written request form from Department of Health that's signed by 2 witnesses, one of whom must be unrelated to the patient. Healthcare team members cannot be a witness, and know that all the witness is attesting to is best to their knowledge that the patient's of sound mind, they're acting voluntarily, and they're not being coerced to sign the request. Next slide. So mental health evaluation. So all patients in Hawaii who request medically and dying must be referred by the attending provider for counseling. And counseling is typically 1 or more consultations with those individuals listed. Know that actually Hawaii is the only state, as well as DC, that requires this. There's no other state that requires a mental health evaluation. Some of them had it initially and then have passed laws to no longer have that be required. Evaluation by the counselor, again, determines, are they suffering from an under-treatment or a non-treatment of depression or other conditions which may interfere with the patient's ability to make an informed decision. Yeah, so just to be clear, all of the states and DC do not require a mental health evaluation. Okay, next slide. And I'm going to refer this to Dr. Charfin.
Okay, so I'm going to talk about the medication. There is a lot of confusion around it. So the first thing I want to say is this is not a pill. I have so many patients that come to me that think, oh, I'm just going to take a pill and go to sleep. This is several different medications. They are compounded. So you have to use a compounding pharmacy. You can't go into Target. You can't go into Long's. Okay, so I want to go through this to make sure everybody understands this. And yes, pharmacists play a huge role in education for the patient and for the clinicians. There are some guidelines we like to try to go by prior to the day of ingestion. So one of those would be, you don't really need to take any special medications besides those that give you comfort 12 hours prior to an ingestion. The other thing is we really want patients to be in PO, nothing by mouth, 4 to 6 hours prior to when they've decided they want to use the medicine. And the reason, there's a really practical reason behind that. First of all, we have to use the gut, right? This is self-administered through the GI tract. So we want the gut to have the best chances of absorbing this medication quickly. So that's why we don't want any food sitting in the stomach. The other thing is, as people are approaching the end of their life, the GI tract is starting to shut down. There may already be a lot of nausea and vomiting due to the disease process. So we want to decrease that effect of possibly vomiting something that's in the stomach. Definitely no dairy. And the reason behind this is dairy decreases the absorption of those medications, as do the heavy laxatives. So prior to taking the actual medicine that comes in a bottle that is a powder, again, not a pill, the patient is pre-medicated with anti-nausea medicine, usually 1 hour to 30 minutes prior to when they're ready to take the medicine. And so those medicines, there's 5 in the bottle that are going to come from a compounding pharmacy. I'm going to say I live on the Big Island. I do not have a compounding pharmacy that will actually create this medicine for my patients. So I have to use a pharmacy in Oahu. That's important for neighbor islands that don't have access, like my island, because that will increase the time to which the patient can get their drugs. So that's just one thing to keep in mind. But what's in that bottle? So if you understand what our goal is, and it can make sense why we have 5 different medications. So we want a quick, peaceful, painless death. That is really what we're going for. So we want someone to go to sleep quickly, and we want their heart to stop as quickly as possible. Okay, so that first drug, digoxin, that's a heart medication. Many of you probably are familiar with it. It's been around for a very long time. It actually helps the heart in normal doses, but we're giving this medication in a very, very large amounts. I'm from the South originally. So back in the day, little Southern women would make oleander tea to poison their husbands. That's what this comes from. So in high levels, it is cardiotoxic, meaning it will stop the heart. Diazepam is also known as Valium. A normal dose of Valium for anti-anxiety would be like 5 to 10 milligrams. We're giving 1,000 milligrams of diazepam. That is going to get someone to sleep very quickly. Most people know what morphine is. Used a lot, especially when someone is having severe pain, especially at the end of life. We're giving 15 grams of morphine, very large dose. And what the idea behind that is, again, sleep very quickly, but also it decreases the respiratory drive, right? It's basically an overdose of an opiate. Amitriptyline, not everyone is as familiar with. That's, again, been around for a very long time. It's what's called a tricyclic antidepressant. In very large doses like this is also cardiotoxic. This is the medicine that I always educate around when I'm talking to patients about when they're ready to ingest, because this is what burns. This is bitter. This medicine does not taste good. And so there's a preparation and education that I do as the attending provider, but also pharmacists will do. It's a repeat. This is something that's repeated, and we prep for this. So there's no surprises that this is not going to taste good, and that we're going to have something at the bedside to help that, whether that's a non-dairy sorbet or whether that's just water, so that they have something to swish or put in their mouth to help with that burning sensation. And then the last medication that's in the bottle that's compounded is phenobarbital. This was just recently added within probably the past few years. Deep sedative, it's a barbiturate. It's actually used in palliative sedation a lot in hospices, but this again is at very large doses. What I'm going to tell you about this prescription is, since I've been doing this, since we've gotten our law in Hawaii, this has changed now 3 times. So it's just best practice, and you're looking at the best practice as of now. As we collect more data, that could actually change. But this is what most clinicians are using at this point in time. Next slide. And so the process, the medication process, that top line, having a prescription for medical aid in dying is palliative. It's a pretty profound statement, and I want to make sure you really soak that in. What does that mean? I see this time and time again with patients that are contemplating the process or going through the process. The act of just getting access to this medication can significantly decrease anxiety and fear around someone's terminal disease, whether they choose to use the medicine or not. So that to me is super important to recognize when people are thinking about this. This can be so helpful just to know it's there. It's like it's a safety net for them, for a lot of people. And then medication education, very important. Again, people are getting a lot of information at the end of their life, not just through this process, but if they're in hospice. So I repeat myself multiple times. I think it's important to do that because it's hard to remember everything. I also give resources so that they can go back and review this even after they've talked to me. But a lot of people want to know, how much does this medicine cost? And it really depends. Some insurance do actually cover the cost. A lot do not. So typically with the pharmacy that I use, the last time I checked, it's somewhere between $450 to $475. The pharmacy will dispense it directly to the patient once I have sent in a prescription. I'm an ER doctor, so safety is really, that's just kind of how my brain works. So I talk a lot about medication safety. If a person is going to choose to fill the prescription, and they don't have to, so they can go through the process, they can get access. They don't necessarily have to fill the prescription. They tell me when they're ready. But if that person says, no, I want to have this in my home because it makes me feel better, right? Then we really have to talk about safety and storing that medication. And I talk about it's really, it's like a lethal weapon. This is a lethal medication. It needs to be treated with respect. So it needs to be in a place that's very safe. A locked box is great, up in a closet. But the other thing I want to point out is that person needs to be in control of that medicine, but somebody else that they trust also needs to be in control and know where that medicine is located. I had a patient once who he lived alone. We knew he had the medicine. His mental status completely changed. He was no longer able to take medical aid in dying, but we couldn't find the meds. So a lot of conversation around safety. Self-administration, we've already touched on. Most people think using the mouth, and that is the most common way people that take the medication, but it's not the only way. Okay, so if someone is using the oral route, I always have them practice swallowing. Again, as our bodies are shutting down, the ability to swallow does decrease. Some medical processes, same thing is happening. So making sure they're practicing being able to swallow about 4 ounces of water, whatever they like, within 2 minutes prior to actually the day of ingestion. If someone cannot take the medication orally, they can rectally administer this. That is a little bit more in detail. It's still pretty simple, but I would recommend having a medical provider that knows how to insert a Foley and guide them through that. They don't have to do that themselves. Someone can help them get to that point. The only thing they have to do is be able to push the plunger on the dispenser that's going to go into the Foley. Same thing with a feeding tube, especially our ALS patients will have feeding tubes because they've lost the ability to swallow and feed themselves. So as long as that feeding tube is big enough, the medication can be mixed, put into a syringe, attached to the feeding tube. The patient, again, has to be able to push the plunger, whether that's with their hand or with their chin, which I've seen done with one of my ALS patients. And then what to expect, right? What happens when you take this medication? Well, I think we all know that if someone is choosing to use this medicine, they are hoping for death, and they're usually hoping for a very peaceful, quick death. So sleep usually on average will happen within 5 to 10 minutes of ingesting this medicine. So that is why it's very important to be able to get as much of it down in 2 minutes, typically, right? And then they're going to go into a deep coma. The time to death will vary. On average, I usually tell my patients it's about 1 to 2 hours. We've got statistics that we can look at, but we also have to remember that a person is an individual, and depending on their disease process, their age, all of those things really go into knowing, and I don't have a crystal ball. So my last patient he died in 12 minutes. He was also 98. That's not typical. The longest death I've ever had was 5.5 hours. She was in her 40s and had a really strong heart. We were already prepped for that. Her family already knew about that. So there can be outliers, but usually within 1 to 2 hours, someone will die. It is not immediate like some people think, but it is typically very peaceful. Next slide.
Actually, Charlotte, even though we're going to have most of the questions at the end, one just popped up that is right on this slide. So there was a question about repeating the cost portion of the medication. Could you do that again? Thanks.
Yeah, so I only know from the pharmacy that I use in particular. So I don't want to speak for every pharmacy that's compounding this medication, but typically 450 to $475 is what the last time I spoke to them that they quote. The one I use will sometimes, if a patient does not have the ability to pay, they will help with that. There are other organizations also that can help with that if someone is just not in a space to be able to pay that. Prior to us getting this law, way back in the day when this really first got started, so people were spending $2,000 to $4,000 on this medication. So even though I think $450 can still be an issue, it's certainly much less than in the past.
Thank you. And Susan, anything else that you would add from the Kaiser perspective or any of your experiences?
So Kaiser's cost actually can be anywhere from 0 to about 270. So again, it's going to vary depending upon insurance. And I just wanted to add, and I think Doctor alluded to this, but so once you mix this with water or apple juice, it's about 4 ounces. It thickens fairly quickly. So that's why patients need to actually drink this within a couple minutes. So that's why sometimes it's helpful to have practice swallowing, like with Ensure, with a thicker liquid, just so they can be assured that you can indeed swallow this before you fall asleep. But yeah, I think that's it.
Okay, great. Thanks.
And then most recently, I did pick up a medication over here on Oahu. It was 500. And if it's a Medicaid patient, usually it's waived.
Awesome. Oh, great. Thank you, Michelle.
I will say one other thing about the mixing of the medication. Thank you. It's actually really important. it settles out of solution. So you never mix this medication until the person is absolutely sure they are ready to take the medication. And even at that point, especially if you're using, say, a feeding tube or a rectal tube, it has to be continuously mixed until the moment they're ready to push, or it can clog the tube.
Great. Susan?
Sure. So the conversation, we always would like this conversation to be done upstream as soon as possible when you're talking about all of the end of life options, just because, right, there are some time constraints and people's disease progresses. So really important that whoever may be working with the patient, whether it's a community health worker or a social worker, you know, or a nurse or a physician. It's really important to include this as a end of life option and have patients start thinking about, is this something they might be interested in? And so when would be a good time? So there's a couple times in the relationship that we think would be helpful. One is obviously once you've established some relationship or rapport, this can also, be a difficult conversation, just death in general with patients. When you're talking about advanced care planning discussion, is a good time to, again, talk about all the different options. When patients actually themselves relay concerns about end of life or any wishes that they may have, or if they've got questions related to end of life, those are just always really good opportunities. And I have to say, the community health workers can play a really vital role in introducing, as you can see, there's obviously a knowledge gap that this option even exists. How is, asking patients again if they're aware of all the options, including the MAID law, asking permission to share information, and then just being prepared. I mean, being able to be aware of the law and be able to answer questions and to be aware of resources available to share with the patient. So many times patients have entered the process kind of late in the game, and then it gets really tricky trying to meet their needs. It's certainly easier now that there's a 5-day waiting period as opposed to when it was a 20-day waiting period. So that certainly has helped, but still, it can be really very stressful if you're trying to do this very, very late in the game. Next slide. So I think many of you are probably aware of these communication techniques that are used in many scenarios. But just to reiterate, active listening, right? So really fully being present, really listening to understand what's being said as opposed to thinking about something else or thinking about how you're going to respond, but really trying to understand what's being said. Asking open-ended questions so you really get some verbal communication from this patient and get an understanding of what their thoughts are, paying attention to nonverbal cues. And then, of course, reflection with paraphrasing is also so helpful where, right, you're really trying to understand and then you reflect back, hey, so what it sounds to me like you're saying is, and really confirming that you really understand what the patient's saying. That's such a really important technique with all patients. Next slide. So why are patients asking about MAID? And our next slide talks about here's why. And again, it's multifactorial. There's lots of combinations. Patients are all very different, but common themes are loss of autonomy, loss of dignity, fear of pain and suffering, and diminished quality of life. And I think I've had many patients say to me, I will only take it if I'm in terrible pain, which is fine. But at least, as Doctor had said, there's real reassurance that I have something if I need it. Not that I'm going to take it, but there's really comfort in knowing that there's something there if need be. I had one patient who picked it up. His depression was good. It was pretty amazing, and he was able to actually spend a lot of time with the family and really do a lot of things that I'm not sure he would have been able to without that reassurance that there was something he could have in his back pocket. And next slide. So the roles and responsibility of the navigator, I'll just talk in kind of in general terms. This is obviously going to differ depending upon the institution and the practice. I mean, often the navigator is the nurse or the social worker. You know, in Dr. Sharfin's case, being in a rural area, she's the navigator as well as the provider. So again, depending upon the practice. But really, a navigator is one who's really needs to be objective, obviously compassionate, non-judgmental, and I think have really easy access. I know at Kaiser, we always gave out our cell numbers. Patients could call us at any point, and just really important that they have that ability to ask questions and to have the support when they need it. So typically the navigator, the first interaction, really determining a little bit of their history, and in large part, why are they interested in this option? And then explaining the whole process. So navigator sets up those appointments. So those are with each of those providers. I know at Kaiser, the navigator helps to collate all the forms. So each of those provider has a form, plus you've got the witnessing form, and then they help to get those to Department of Health in a timely manner. Documentation, again, at Kaiser, I can speak to, we have templates, which are really helpful. It helps the provider and the navigator in terms of just being efficient. And then certainly for the providers, making sure you're meeting kind of the letter of the law, that you've got all the components that are necessary. They provide materials for the patients. Kaiser has a specific handbook that's really nice and comprehensive, and a timeline that patients can watch, that they can use. Compassion and Choices, which will give you a reference at the end. They have some nice material for patients, as well as the Academy on Medical Aid and Dying Medicine. So we'll give you those references. And then telephone follow-up. I know that we would always, even once they had the prescription, we would just periodically touch base with them. And check in with them and see how they're doing. So again, differs from, Michelle and Dr. Sharfin's practice may look a little differently, but these are kind of some of the overall components.
So Michelle, any other thoughts from your perspective?
I
Similar?
was just going to say, great resources, Hawaii End of Life Options.
Yeah.
Great new website that just started. So great resources over there included end of life doulas, etc., and the law. And very similar to what Susan shared with Kaiser in terms of the practice and the roles and responsible of whether it be the navigator, be the doctor, nurse, or social worker. So
Great.
Thanks.
So navigator role, right? The key is listening. Again, not to beat this into the ground, but really establishing rapport, looking at who's in the household, why is the option being considered, looking at fears and their beliefs. The family dynamics is really important. Have had some interesting cases with family dynamics and how that plays out. Will the family be informed? And then making sure that other options are discussed in terms of palliative care or hospice alone. We review the process, again, and again, it's repetitive, just because there's so much information being shared. But the forms, the medication, etc. And then just, again, the logistics, scheduling the appointments, offering the support, keeping the providers informed. So sending notes that the primary care provider, hospice, and then I know we use a tracking system to make sure we meet the timeframes that are outlined in the law. Next slide. And I'm gonna send this over to Dr. Sharfin.
Yeah. So just to reiterate, medical aid in dying is just one end of life option. When we got our law in Hawaii, I was actually really excited because I had already seen the data from Oregon. What happens when this law goes into effect, even if a patient's not interested? It opens up conversation. It improves end of life care across the board for anyone that's facing this, and we're all going to face it, right? So some of the options, and this is part of the attending's role, is to make sure their patient is fully informed of all of their options. Of course, they can continue to pursue life-sustaining treatment. That is totally within their right. They can also stop. They don't have to continue. Palliative care, in a perfect world, my belief is everyone that has a serious illness diagnosis should start palliative care. Unfortunately, not everybody has access to palliative care. It really depends on their insurance provider and what options they give. But if they've got it, they should use it, is my opinion. You should use what you can get. Hospice care, if someone qualifies, typically if someone is pursuing medical aid in dying and has decided not to pursue life-sustaining treatments, then I'm a huge, huge believer that hospice, and we'll go into a little bit more detail, should be on board unless the person's just absolutely opposed to hospice care. They just bring a whole team approach that you really can't get anywhere else. Continuous deep sedation, or what's also known as palliative sedation, is an option, but not an option at every hospice. So it really does depend on where the person's located and their hospice. But I do talk to them about that. It is not to be confused with MAID. It's completely different. It's very much at the end of someone's life when their symptoms cannot be controlled, and they can basically be one of the medicines we spoke about, phenobarbital, is typically used to keep someone sedated until they die naturally. But again, it's very labor intensive. So not every hospice really does provide that. So it's important to know that for sure. And then VSED, or voluntary stop eating and drinking, that's an option that's legal to anyone. So I have helped patients through this process as well. Typically, patients that have chosen this option just don't qualify for MAID. It may be because they have a dementia diagnosis and they still have enough mental capacity to choose this option. But again, it's a legal option that's open to everyone. And of course, we're talking about medical aid in dying. Next slide. The art of prognostication. So the law says the person has to have a prognosis of 6 months or less to live. And how do you decide that? Is there a special tool that tells you this is what's going to happen? There is not. And I will tell you, if you look at, and there's really good studies that show that doctors are terrible at prognosticating at the end. We give people way more time than they really do have, but it is an art. It comes with practice. It comes with doing this over and over and over again. And it comes from other people helping as well. So I am very much if I don't know, I'm going to ask. I'm going to ask the specialist that's treating the patient. But in general, if someone has qualified for hospice, they more than likely will qualify for medical aid in dying. Only a few circumstances like dementia that I would say wouldn't be a qualifier. But in order to be in hospice, you typically you have to have a prognosis of 6 months or less to live. And that has to be certified by that hospice physician's opinion. And that is a Medicare requirement. So when I have a patient that's already in hospice, it does make my job as the attending provider a lot easier. Is there a specific tool that you can use? No, there's not one specific tool, but there are lots of tools out there. So with my ALS patients, and I've had this happen where they're really on that borderline, there's some tools you can use for certain disease processes, but really this is more of a clinical judgment. You don't have to get it right every time. By the way, I've had some physicians that actually I had a hospice provider who had actually certified the hospice patient, and she's like, but he's getting better. And I'm like, well, that does happen in hospice. So she was a little bit like waffling whether he really met criteria. He met criteria. It's okay if somebody improves. My patients love it when they improve on hospice. That means they got more time. I love it when I'm wrong. That means they got more time to live and be with their family. We do the best that we can. Again, it's an art. And if you don't know, you seek a second opinion. You talk to their specialists. Most of the patients that come to me are cancer patients. So I often will be speaking with their oncologist, making sure that a lot of times they will be my consulting provider. If they don't feel like they can take on the attending role, either ethically or because their health system won't allow them to, a lot of them will take on that consulting role, which gives me that safety net of knowing, okay, we're on the right track here. Next slide. And I'm gonna.
You have a short story for us.
A short story. Yeah, I have a lot of stories. I'll try to keep it short.
Do you want me to go to the next slide?
Yeah, please. I have many patients, but this is. I hate to choose favorites, but this is it's a really sad and beautiful story at the same time. So I was asked to help this gentleman who had his own primary care doctor, who had end-stage COPD. He lived on the other side of the island. He was 68 years old. And he thought, he knew he was dying. He was actually well-versed in our law. And this was when we had a 20-day waiting period, by the way. And he thought he had had a conversation with his doctor. And so when he went to give what he thought was his second verbal request, meaning he'd already waited 20 days, and said to his provider, his doctor, hey, I really want to access this law, this medical aid in dying law. His doctor freaked out and said, oh, no, 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 no. I don't do this. And if you want to die, you can go home and die naturally, or you can drink a bottle of Benadryl. And it was really sad to me when I heard this. I didn't want to believe it, first of all. I wanted to believe that the patient did not hear correctly, but he had a witness there, so he did. And the first thing he asked me when we got on the phone together was, is that true? Is that all I need to do to die peacefully? I'm an ER doctor, and I was very blunt with him. I'm like, that's the worst thing you could do. One, you don't usually die of a Benadryl overdose, and if you do, it is horrific. And so I very much felt very close to this patient. It was a difficult patient. There were lots of dynamics going on. Single dad, 12-year-old daughter. I mean, in order for us to do our intakes, he had limited internet and phone connection, and I'm not joking. He would go and stand on a certain rock to be able to talk to me. He had a very hoarse voice, so it was really hard to even understand him. His only adult caregiver worked full time. She had a language barrier, so even going when she could go to office visits and understand medications, instructions, it was super limited. Again, I'm a big advocate for hospice, and I kept telling him, you need to be in hospice. He'd already been in hospice and he had fired them once. And I'm like, but listen, if you're really serious about this, and he was pretty adamant he was going to use the medicine, I'm like, you really should be in hospice. They're going to provide support, and the police don't have to be called. So he took my advice, and I can't remember, he lasted less than a week on hospice, and he fired them, which, by the way, is okay. And that's what I tell patients. If it doesn't work for you personally, that is okay, but could you just try it? It took him 45 days, and it would have actually taken longer had his primary care physician not documented the oral request in the medical record, but 45 days before he could get his medicine. He told me on the day that he died, this was the hardest thing he had ever done in his entire life. He was a veteran, so I knew he had done a lot of hard things in his life. Next slide, please. Yep. This is Gary. And Gary gave me permission to share his story, talk about him, talk about what he went through, because he made me make a promise on the day that he died that I would do everything in my power not to let this happen to another person. It's one of the reasons I talk about this, and I continue to support patients through this, because he really could have turned into a terrible end of life experience for him. Instead, I don't think that's what really happened once he started accepting other help. So we had doulas that I had helped train down in his area. He wasn't really into having people he didn't know in his home, but he reluctantly let two of them in. And they supported him. They supported his daughter. They worked on legacy projects together. They became my eyes and ears, because, again, really hard to communicate 2.5 hours away. When they saw something that needed to be addressed, they would contact me. So it was even though we didn't have a ton of support, we made it work. On the day of his death, he wanted us there, his doulas, myself, his daughter, the mother of his child. He had a few close friends. They did this really beautiful goodbye party. He had a ceremony honoring his heritage. One of my favorite things that he did was Compassion and Choices had done an article about him. He printed that off, and he had the doulas addressing it to send it off to all the people he felt should read his article, including Dr. Benadryl. He died very peacefully. I can remember him holding up his glass and saying, "Beam me up, Scotty," and drinking his medication, and then dying in the arms of his the child of the mom of his child, which was a peaceful death. But again, I had to call 911 because it was what will be considered an unattended death. So the police, EMS shows up, they confirm he's dead. Then they had to call the police, and I remember looking at the doula saying, this is the number for my lawyer just in case, because they looked at me like I had done something. They didn't know about the law. Luckily, I had already called the police station and spoke to the captain and said, "This is what's going to happen, and I just need to know how I can do the best I can for this gentleman." And he said, "Make sure you have all the paperwork," and I did. And so it turned into actually being an education for the police officers there who had never heard of our law. And then it turned into them asking me to come to their department to educate. So what could have been a really bad situation turned into that they left. Everything turned out just fine. And Gary's memory lives on inside me every day. Go ahead. Next slide. Hospice. Yeah, Gary fired hospice, and I wasn't really that happy about it. But again, his choice. But truly, hospice is, I can't recommend hospice enough. I work with many hospices. I am not a hospice provider. I just really believe in what they do. Their philosophy is that everybody is entitled, every person is entitled to comfort and support and control over how they are going to spend the last days. It's a whole person care approach. You know, in medicine, we're really not that great at that. Hospice is beautiful at that. Really not just approaching the physical, but of course they're going to, but that person's emotional, spiritual, and social dynamics. And that's what I think is beautiful about hospice. It is a Medicare benefit. So if you qualify, it's paid for. It's not coming out of someone else. It's not coming out of your pocket. You've already paid into it, right? You do have to have that 6 months or less qualifier. And what I'll say is, you know, there's lots of anything in stage pretty much should qualify, right? So in stage cancer, if somebody's on dialysis and chooses not to be, those are all pretty easy to get into hospice with. But then there's some like on the borderline type of concerns. And then they'll look at other parameters like someone's functional, nutritional, and neurological status, and then that goals of care at the end. And I think that's all I want to say about hospice. Go ahead. Oh, end of life doulas. So I am a big advocate for this as well. I am one, and I teach end of life doulas, and I believe anybody, whether they choose medical aid in dying or not, if they could have access to an end of life doula, it's just another level of support. If you're not familiar with end of life doulas, I think they're becoming more known. Now, most people have heard of birthing doulas, kind of similar in that you're supporting someone through the end of their life, not the beginning of a life coming in. By definition, they're non-medical. Even though I'm a medical provider, my training as an end of life doula really doesn't sit on the medicine that I already know. But you're there to be another level of support. And I think of them as educators around the emotional, physical of what's going to be happening at the end of life. Really being able to educate the family, the loved ones, and the person of what to expect and how to support non-judgmentally all end-of-life options, whatever that may be. Now, there are doulas that really, I'd say, specialize in medical aid in dying. They've been doulas. Now they kind of stepped into the world of really, how do I help navigate for patients and support patients, be there on the day they choose to ingest or just get them through the process. If I can get a end of life doula on board with any of my patients for this reason, it can be just really so helpful. Like I do see patients in Oahu on occasion, and only if I can have an end of life doula that can help me get the patient through. So they do a lot of that emotional support, logistical support, coordination, kind of that navigation we were already talking about, in addition to bringing their own kind of specialty into what the patient wants, like the life review and the legacy projects that like Gary was interested in. Planning an event at the bedside. I mean, they've done pretty amazing things on the ocean, on a sailboat, et cetera, et cetera. Can't say enough about end of life doulas, but I will stop with that. Next slide.
Susan.
Sure. Yeah, and I just wanted to add something. It's also, we really recommend that patients have a pulse for obvious reasons. Just wanted to add that. But just a little bit more about hospices. So in Hawaii, we have 11. I spoke to all of them, and 4 of them were kind enough to actually share their policy with me regarding medical aid in dying, which was really interesting. I have to say that one of the policies does use the term physician-assisted suicide. So I recently spoke to the hospices, and hopefully they're going to take a look at their policies. But when I looked at them and talked to them, they informed me that, for example, as a consultant, they were using 3 of their 3 of the hospices were using their providers as a consultant. One of them actually was using a provider as an attending. One hospice actually allows the nurses or the staff to mix the medication at the bedside. And then 6 of the hospices allowed staff to be present at the bedside. So you kind of see where everyone, how it sits. I did ask them about, do they initiate discussion about medical aid in dying? And I was told actually none of them do. It's only if the patient themselves bring it up will they then address it. And some will help, with the process. So I just think it's important to know, for those of you that are involved with hospices, is likely that your policy was probably written right soon after the law was approved in 2019. So it may bear it might be important to review that policy to see if there needs to be any changes. And I think nurses can play a vital role in that process. I do want to share with you kind of an interesting quote that I recently read an article, and we referenced this again at the end of the presentation, but it was an article titled Hospice Policies on MAID, Current Practices and Recent Progress. And it was in the Journal of Aid and Dying Medicine. And it was just really, this quote struck me, and I just wanted to share it with you. And it read, quote, "Institutional policy requiring nurses to leave the room during the ingestion of aid in dying medications is ethically unsupportable because it risks violating professional nursing standards." So just kind of food for thought. I'd encourage you again, if you're involved in a hospice that doesn't allow staff to be at the bedside, that maybe it'd be good to have a conversation around that. Next slide.
And now we're going
And
to
Michelle.
transition to Michelle. Yes, absolutely. Michelle?
Sure. Go ahead to the next. I'll tell you I have many patient stories as well, but I wanted to include something that, like Charlotte shared, that a lot of patients, they may be simple and complex, and I've had both recently. This patient, she was lung cancer. She was discharged home, and she couldn't go home. She had to go to a foster care home with home oxygen. And she was a nurse, retired nurse, and she, us nurses, kind of A and all, but she knew this is her choice, and she wanted the opportunity to have it. And so basically, why MAID? Like she's like very, she's able to get to the bathroom, but it's getting worse and worse, as we know, with the lung and the deficits and stuff like that. What was really important to her was her children, her grandchildren. She had 2 daughters. One she had a big argument with, so she wasn't talking with one daughter, and then the 2 grandkids from each daughter. And her grandkids were her joy. What was her fear? Her fear was dying. But most than that, it was the fear of the kids not accepting her death, right? And that was her worry. And did she want her grandchildren to be there at her bedside when she took the medicine? Yes. One kid was 16 years old and the other was 19. So teenagers, you know. And then one of the daughter who she had the argument with was her granddaughter. And I was like, well, I don't know if you should be having that conversation as yet. So very importantly is like when we met about her fears and her worries, and even though she says, I want this, I said, you know what? Sometimes we have some of our patients do want to feel like the anxiety is there. We got to get everything in place. We got to get the check boxes, within the 5 days now, etc. But sometimes we also have to step back and take a breath and take a pause because for her, I told her you have to do some homework. Your homework is like working with your daughters and then working with the grandchildren. And because those were her greatest joy. Was she religious? No. Was she spiritual? She accepted and she believed in the grace, right? The grace of the universe. And what was important at that time, and I do stress hospice, I'm one is like, I don't feel comfortable if you don't have hospice. They're there to pronounce you, they're there to support your family. And I can't thank the hospice enough because they did pre-bereavement work, not only with the patient, but the grandchildren, and then working with the daughters. So before, and then after. So very important. And then, and Charlotte said, brought in the end of life doula. The first end of life doula, okay, she was like, okay, not quite sure as yet. But then the second end of life doula was a child life therapist. Boom, help with the children and grandchildren. So it took 7 months for her to kind of work through. We kept getting phone calls and keeping in contact. I didn't get the prescription. We went through the steps, but we're like, you let me know when you're ready to get the prescription. And then within the 4 months or so, then she's like, okay, Michelle, let's get the medication. And then we had to arrange from the foster. Couldn't do it in a foster care home, so she went back to one of her daughter's home. And the plan was that she made up with her daughter, and the grandkids were there, and everybody was there within the weekend. And she took the medicine on a Sunday, and she died peacefully. So really, a lot of work sometimes needs to be done. Sometimes when people are anxious about it. And then most recently, I had a patient who's like, why are you doing MAID? And he had prostate cancer. And he's like, Michelle, I've seen my dad died from cancer. I've seen my brother died from cancer. I don't want to go through with this. I don't want to be a burden with others. I'm not fearful of dying. I'm accepting it. And he was so at peace, like when I met him. And I was like, you're still functional. You're still okay. And then within the last 3 weeks, and I just saw him last week, it's like, oh my goodness. The decline is just so night and day. And was he ready? He wasn't religious, but he brought up Christian. He was brought up with very Buddhist thinking. And he says, Michelle, and we talked deep, and he's like, Michelle, I told him his last words, what are you going to tell me? What message are you going to bring back to me? He's like, Michelle, when you feel that breeze across, it's going to be me. That was our conversation together. It was so beautiful. So for him, he was so at peace, and thankfully his family was from the mainland, and they came over to help to support him. So different. But I tell our patients, they're so courageous when they go through medical aid and dying process, and their families. So very important. Next slide.
Just a reminder, we will be answering questions at the end. So if you have questions, put them in the chat, and then we'll get to them as soon as we can.
We do not start the process for us at any of our HPH hospitals inpatient. We can start the education and discussion. Our social workers can do it, as well as the palliative care team. As soon as they're discharged, they can give us a heads up. Well, we kind of know it before, and then we could start the process after. And everything that Susan mentioned, including, I saw the question about pulse, have to have a pulse, because I tell them, very important for EMS, first responders, to follow that medical order for do not attempt resuscitation. And we can go to the next slide. So bereavement and the medical aid and dying bereavement support is run by Leilani. She's a licensed clinical social worker, and she also does the mental health consults as well. And Joy Rodriguez is an end-of-life doula. And they started this, I think it's going into their second year for our Hawaii. And it's for the families who, even if they took the medication or did not take the medication, it's free and every Sundays. And it's so important to have this, because one of my patient's husband, he's like, Michelle, it's so different going to the hospice bereavement support group, because I can say my wife took this medication to end of life just because of cancer. It's kind of a different, so he 100% enjoyed being there, and I think he stayed there for the whole year. It's just, very reassuring. Next. Update on
We're going
numbers,
to do a
Karen?
quick update on the numbers. So Susan?
Sure. So when you look at the 6 years since medical aid and dying has been legal, we've had 361 prescriptions written in the state. The number of known qualified patients died were 299, and then those who died from the drug is about 195. So typically, you're looking at about 54%, about half. If you look at nationwide, you're looking at about a third of people that actually end up using it. So you can see some gradual increase in the prescriptions written. There was some dip between 23 and 24 that may have been related to some staff turnover, Department of Health, and some more paperwork issues. But for the most part, not huge numbers, but certainly enough numbers where we've gotten some good experience with medical aid and dying. Last year, there was one advanced practice RN who was the attending, and 4 of those were consulting. So hopefully, again, over time, that will pick up just to improve access for patients, especially in the neighbor islands.
And as a reminder, this is the Department of Health data, right, Susan? So this means that people
Right.
went through the process. So Michelle is going to talk about the bigger picture numbers. Michelle?
Oh, sorry. This is together for Kaiser and HPH. So very similar with our organizations, as Susan shared. They do a log. I keep a log for us. And looking at the amount of referrals overall, how many patients were really wanted education on this, and then how many of them end up getting the prescription and taking the medication. So, again, about 50% overall for both sides of HPH and Kaiser. Next slide. Within the 5 years. So specifically for HPH, in terms of ethnicity, you could see that 56% were white Caucasian and then Asian was it's Filipinos, Japanese, Korean, that basket, and Native Hawaiian, 9%. And then the breakdown, 68% Oahu and Kauai. We support we have Walcox Medical Centers, and hence our numbers are over here. And then Maui and Big Island for us at HPH, because our oncologists go over to those outer islands. And definitely 82% of our patients are cancer diagnosis. Next slide. And then breakdown of demographics. Legal age to doing medical aid and dying is 18. We did have a patient from Kapilani who inquired on the process. He died naturally, but it was Dad who had called me. Very courageous, very strong, and he's like, "Yes, I hate calling about this, but I want to support my son." And then you can see the breakdown, the age group between the 60 and the 80-year-old population, and the breakdown of male, female. Next slide.
And Susan's going to talk about liability. Susan, any other thoughts about the demographics or age from Kaiser's perspective? I think it was fairly similar, right?
I think it's similar, right? And the main diagnosis is cancer across the board. But yeah, similar to what Michelle shared. So liability, again, no duty to participate. So I know at Kaiser, if you have what we would call a conscientious objector, what Kaiser asks is minimally, if someone then presents to that individual with requests about MAID, that they at least give them an FAQ sheet so they know how to proceed. But again, no duty to participate. There's no liability as long as the medical team is acting within the law. No disciplinary action taken against a licensee by any state board for participating or declining to participate. Under Hawaii law, you cannot be denied health or life insurance or any other legal medical contracts. Again, death certificate is not the terminal, it is the terminal disease, not MAID. And again, does not constitute suicide, mercy killing, or homicide under the law. Next slide. So ANA has a statement. Again, the full statement is on the link at the bottom. Delivering of high quality, compassionate, holistic, patient-centered end of life is central to nursing practice. I think the key, right, is remaining objective when discussing end of life options, having an ethical duty to be knowledgeable, being aware of your own personal values and how those will affect the relationship. And then, of course, never abandoning or refusing to provide comfort and safety if the patient chooses medical aid at dying. Next slide. So just some resources. Department of Health has the timeline. They've got all the provider and patient forms, how to apply for a DEA license, obviously as a prescriber that you would need that. The Academy of Aid and Dying Medicine, it used to be called I always get this mixed up. American Clinicians Academy on MAID. It's recently changed their name. Great resource. It has sections for patient and families. It has clinical resources. It's got a clinician hotline. It's got a list of the red flags to be aware of in terms of possible prolonged deaths. Has courses. It has lots of articles. That article I quoted about hospice policies is on there. So really good website. Compassion Choices, again, lots of really good material. They do have a guidebook to help patients through the process. Um, and as they really were instrumental in helping to pass the law in Hawaii, they've kind of moved on and are helping other states. So I know Karen's going to talk about Hawaii end of life options and how we're hoping to fill a little bit of a void from when the Compassion Choices moved on.
So I'm actually going to skip this slide just so that we can do the Hilo slide. And then Malia, I'm giving you a heads up. We're going to do the post-test questions then. So thank you, everyone, for the great speakers here. Yes, Hawaii End of Life Options is about 3, 4, 5 months old now. We have had the pleasure of having Compassionate Choices in the state for a number of years, and they really had a lot of focus on helping with designing and drafting all of the language for the law and helping to get that passed. And they also were helping to do education and outreach. But then right after, as we started to have the law passed and we did some changes to the law, Compassionate Choices decided that they had other states to probably start focusing on. So there's a bit of a gap for us because they moved on at the end of June last year. So we're trying to figure out how do we help people that are still asking questions. And Aubrey Hawk and Samantha Trad and Susan Amina and Michelle Cantillo, actually Charlotte, we got a lot of feedback from people about maybe we need to start to figure out a way to do this. So Hawaii End of Life Options is up and running now. We have a couple of ways to contact us, either voicemail, but obviously electronically as well. And we're really focusing on public and education and provider education, patient support, and working closely with hospice and healthcare providers on continuing to incorporate medical aid and dying resources into the various organizations. So we're really happy to be working with Hawaii Public Health Institute on this particular CEU and hopefully more in the future. And we are really grateful for all of you that chose to participate with us today. So we are going to now go to the post test questions. And Malia, I'm going to stop sharing. Are you there? Aha, there it is. So if you could take a minute and fill out our poll, that would be fabulous. Poll STEM cannot vote. Oh, we can't vote. Just FYI for everyone that's on the screen right now. So please, if you can vote, and Malia, help me know when you think you've had a number of people complete the survey. And in the meantime, let's take a look at other questions that might be in the chat. Aubrey, are you out there? Do you have a question or two?
I am. Yeah, thank you. I think a portion of this has sort of been answered already. Actually, let's talk about, we did have a question about voluntary stopping eating and drinking being used as a route to become eligible for medical aid in dying. And this is, it definitely can be done, but it needs to be done in conjunction with a medical professional who can handle VSED. And it is also a little bit controversial, but I think Susan, the ACA MAID formerly, now whatever, they have been looking into this and exploring it, and it is an option that some people are considering. I have no knowledge of this being done in Hawaii.
So maybe
I don't, yeah,
Susan
I don't
Charlotte?
either. Sure, I don't know of anyone in Hawaii, but I do know that the Academy on Medical Aid in Dying Medicine has some information, some articles. It is some preliminary data. It is somewhat controversial, but there is some information on it on that website.
Dr. Sharfin? Any?
Yeah, I don't know of anyone in Hawaii who has crossed that bridge either. However, again, Thaddeus Pope, I think there's a video and he's written an article in favor of that. There's also on that same website an article not in favor of that. So I really think that is a clinical decision based on that intending provider and their comfort level.
Okay.
Oh, the other thing I would say, it would depend on also the state's waiting period. So when you're doing VSED, the point at which you are terminal is up for interpretation and also length of time. I'm not going to go down that rabbit hole, but yeah.
Okay.
Okay, thanks. So I'll move on to the next question. This question is from an EMS professional. Dr. Sharfin, you answered, I believe, and Susan, about, we do recommend a pulsed for patients, but what kind of education should be done with the patients and families to prepare for how the death is called, and maybe talk a little bit about why we definitely recommend hospice for a MAID patient, because there is the concern of EMS professionals having to attempt resuscitation if there isn't a pulse, unless the person is obviously dead. So how do we prepare for that?
And even if they're obviously dead, they actually may even attempt resuscitation without a pulse. So yes, absolutely. As in Gary's case, he had a pulse. I had it right there. So when EMS showed up, shocked that I'm calling them, they knew they did not need to resuscitate this patient. And that is definitely a discussion that I always have. Like, that's part of my intake is, let me see your pulse. And if you don't have a pulse, let's do one together, right? Hospice also addresses that. It's pretty rare that someone is not in the hospice setting when they choose to use medical aid in dying. I think on average, it's over 90% of patients are in hospice. But like in Gary's case, if someone's going to choose not to be in there, that certainly has to be in place, because it's traumatizing for the family to have to go through all the dynamics that happen when there's an unattended death.
And I would just add at Kaiser, we educate the family and the patient too, but the family do not call 911. Right? They've got the resources to be able to reach out to the attending provider directly, easily. If in the rare case they're not on hospice, that attending will come and pronounce. So again, we reinforce, have a pulse, but do not call 911.
Thank you. Malia, can you
Well, I will just say this, though, because I have had other patients that didn't necessarily use MAID, but they couldn't get into hospice. They were dying over a weekend. I took over as the attending role. You still have to call. But if there is a physician on site that's willing to pronounce, then they don't have to transport the body, but it is up to the discretion of the actual officer that shows up. Again,
okay.
why hospice should be
Karen,
involved.
did you want to?
I want to just have Malia post up the results of those questions, so just so we can make sure to go through those four.
So from my end, it looks like I'm sharing, but in case people can't see, I'll just share the results of the questions. So the first question was, the provider can administer the medication upon patient request. We had 13% of our participants respond true, and 87% respond false. Our second question.
Oh, so let's just make sure that we're clear on that one. So Dr. Sharfin, can you?
A physician, a provider cannot administer the medication. That is an absolute no, 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 no. You can mix the medicine. You can hold the cup. You can hold the straw. You can insert a Foley. You cannot administer, however. That is strict in every state that has this law. It must be self-administered.
Great, thank you. Malia, the second one?
Yes. Question 2 was a mental health provider evaluation is not required for medical aid in dying. 17% of participants today responded true, and 83% responded false.
So Michelle or Susan, required?
Yes, so mental health evaluation is required in the state of Hawaii. It is the only state that requires it. But yes, it is still part of the law.
Great, thank you. Third one, Malia?
Question 3 was, once DOH receives the forms, the healthcare team will be notified to proceed with MAID. We had 57% respond true and 43% respond false.
So
Michelle?
I must have talked too fast on
Susan?
that point. I think I talked too fast. So again, think of DOH as only data collection. That's it. You're sending in the form, they collect the data, they have nothing to do with the process. They're not going to notify you to do X, Y, or Z. So my New York speed must have been a little bit too fast there. Sorry.
Well, and many times, and Charlotte and Michelle and Susan, please correct me, all the forms could actually happen after
Oh yeah,
after the whole process.
I don't send in any forms until I'm done with the process. Like that, yeah. So it is again data collection. They ask that you send it in within 30 days of writing the prescription. And so I try to do that just so that we have accurate numbers. But otherwise, that's it.
Thank you. It's a confusing process, I'll tell you. It's complicated. So, Malia, what else?
So our last question is, MAID patients are not required to be under hospice care. We had 91% of people respond true and 9% respond false.
So, Susan, I think you spoke to that.
Yes, so it's not required, but we highly recommend it for all the reasons that Dr. Jarfin explained.
Great. Okay. Aubrey, any other
Okay.
questions?
We
Yeah.
have a
Yes,
few
we do have a
more.
couple more.
The next one
Sorry.
is about emergency. This is similar to the other question. They're asking about the medication. So someone is concerned about the safety of the medication and then what happens to the medication if it isn't used.
That's a great question. Yeah, I'm sorry I jumped in. Yeah, so if the medications are not used, that is actually another reason why there's needs to be somebody involved that knows where those medications are so they can be safely disposed of, right? So that, hospice can either take them back. I will take them back and dispose of them properly. Even the pharmacies, if you want, they'll ship something to dispose of the medication. But that's a very good question. You don't flush them down the toilet. There needs to be a handoff of those medicines. You can go to Long's and turn them in there.
I think we might have time for maybe one more, either Sam or Aubrey, and then we have to close out. So,
Okay, sure. And this one is for Dr. Sharfin, I think. What is the prerequisite to train as an end-of-life doula? Where might people obtain this training, and how long does it take?
Okay. So it depends on the training. I'm going to preface this by being an end-of-life doula, there is no governing body. Okay. Just like, so for being a medical doctor, there is. I have to follow XYZ. End-of-life doulas, that hasn't happened yet. So as far as getting training, you can go train anywhere you want. There's multiple different trainings in our country. I teach one. The one I teach, it's 3 days. Now, is that enough time to become an end-of-life doula? No, that's an introduction. I'm giving you a lot of education all at once. And then the training that I help facilitate, then you have to do several hours of volunteer work after that in the field of being an end-of-life doula. The training I took two because I was really interested and I was a really busy woman, and I did one online that took me 6 months to do. So there's several out there. I can't tell you one's better than the other. I think it really needs to fit with your lifestyle and what you're trying to get out of it. I have people that do our training that they don't really want to have it as a profession. They just really want that to help support a loved one, or they just are very much drawn to that. Others want really to do this as a profession. Sorry, there was more to that question. And then as far as the people that come, lots of social workers, nurses, a few doctors, massage therapists, people from all backgrounds are welcome to be end of life doulas. They all bring a certain skill set. People have been doing this a lot longer than the term end of life doula. So there are people that have this really specialty. They don't call themselves that. So it varies.
Really quick, just how can people sign up for your training?
Oh, so you can go on my website, which is drchacha.com, or I usually facilitate with my dear friend Bobby. Her website is inspiredendings.org. It's also on our nonprofit website, ldwellness.org. There's one in May. I'm not facilitating that one, but it is a 3-day training that's coming up. But I'll be doing one eventually. So. Yeah.
So we can work with Malia and Maka on they're sending out the rest of the CEU information, and we'll add other resources. So Dr. Sharpen, maybe we can get those from you, and then we'll send that out to all the participants. We are at 2:30. I think that our team will stay on after this, but we just wanted to thank everybody for participating today. You had great questions along the way. We hope that we provided some information, insight, and education on medical aid and dying here in Hawaii. We will hopefully be doing a few more of these in the next few months. So tell your friends and family. And we will definitely make sure that all the questions that were in the chat get addressed as a follow-up. And on that note, Malia, Maka, I will turn it to you for the sign-off.
Nope, that's it. Mahalo, everybody. For those that are still on the call, we want to thank our wonderful panel today for speaking to you all and for sharing such wonderful and knowledge and just amazing expertise with us. Shout out to Karen for being our amazing moderator today. And I'll also give a shout out to Samantha and Andre in the background. I know the background work is a lot, and I saw the chat and the Q&A getting flooded with some questions. So kudos to all the mana wahine that are here on the panel today. Just a reminder for folks, Mahalo emails are being sent out to you all shortly after this webinar. And a reminder to please submit your evaluation feedback by the end of next week, Wednesday, April 23rd. So that way we can get you folks your certificates of completion. Mahalo nui and have a great rest of your day. Mahalo, everybody.